Good morning, Wendy. How are you?
I'm good, thanks. How are you, Rich?
I'm great. So I'd like to introduce Dr. Wendy Cole. Dr. Cole is a wound care research at Kent State University of Podiatric Medicine, the director of wound care research at Kent State Podiatric Medicine. So I'm going to turn it over to you and interested to see your presentation.
Okay, great. Thanks so much. Share my screen. All right. Can see everything okay?
I can.
Okay, excellent. So
Yep.
as Rich mentioned, I'm Dr. Wendy Cole. I'm the Director of Wound Care Research at Kent State University College of Podiatric Medicine. And today I have the honor to speak to you about the at-risk diabetic foot. So our objectives for this discussion today would be to review the diabetic foot and the disease statistics associated with it. We're going to discuss factors that contribute to diabetic foot ulcer development, also discuss the components of a thorough diabetic foot exam. And I hope to introduce you to some findings of a unique study that we performed with a novel shear and pressure detecting camera system. So as you can see, this house has some problems. It doesn't have a good foundation, and without a good foundation, the structure will not stay together well. Go ahead and make an offer. I don't know that, there's many offers on a house like this, but I put this photo in just to relate to our patients without a good foundation, without good foot mechanics and biomechanics and foot structure, our patients also will develop other disease processes throughout the body and lead them down a bad path. So, for instance, this is one of my patients. You can see this particular patient has a poor foundation, if you will. She is a uncontrolled diabetic. She has some Charcot changes, which we'll discuss what Charcot is a little bit later in the presentation. But you can see structural deformities. She's got what we call rocker bottom foot. Her midfoot arch has collapsed. These are areas of pressure and rubbing, and subsequently she's developed ulcerations. You can see a lot of changes in the skin of the lower extremity. You can see some dryness and peeling. You can see some color changes. You can see, again, an area of pressure on the distal toe on the left side. So again, she's got some structural problems that have led to other issues, and as our job as podiatrists, wound care specialists, is to really prevent these things from happening and supporting our patients and educating them and doing thorough exams so that this isn't the end result. So let's talk about the at-risk diabetic foot. Diabetic foot ulcers are unfortunately one of the most common preventable complications of patients with diabetes, but too many patients are developing diabetic foot ulcers and having poor outcomes because of them. It's been estimated that about 15 to 25% of patients with diabetes will develop a diabetic foot ulcer within their lifetime. And approximately 20% of hospitalizations with patients that have diabetes are due to deterioration of a diabetic foot ulcer. So our patients have diabetes, they're poorly controlled, they're not managing their foot disease, they're not doing diabetic foot checks, wearing appropriate shoe gear, they develop ulcerations, they're not adherent to care or possibly are uneven unaware that they've developed an ulcer. The ulcer gets infected. Unfortunately, they become hospitalized and have to undergo surgery or long-term antibiotics. And, the worst case scenario is if they then would develop a severe enough infection or lack of blood flow to the area that necessitates an amputation. And it's estimated that 85% of all non-traumatic amputations of the lower extremity are because of diabetic foot ulcers gone bad. So as clinicians caring for patients with diabetes and people that are at risk, we really need to take a step back and figure out, what can we do? We've got to be able to do better. So this one size fits all mentality is something we have to move away from. When treating a diabetic foot, the characteristics of each individual, so a good thorough wound assessment or foot assessment, a good thorough patient assessment is really important. That way we can evaluate and treat each individual patient appropriately. So you have to understand what the patient's goals are, what the patient's lifestyle is, what is their work environment? Do they stand? Do they sit? Do they not work? How mobile are they? What type of shoes do they wear? What medications do they take? What other comorbidities do they have? So it's really important to get to know our patients and do a full patient assessment and really develop a relationship with our patients, because I think when a patient feels engaged with their provider, we have a better chance for good outcomes. So I'm going to go through this algorithm. I think it's really important to understand how diabetes affects the lower extremity and the foot in particular. So this is a schematic that was developed by the American Diabetes Association, and obviously the American Diabetes Association is a very good resource for patient educational materials and clinician education materials as well. So, you could see at the top of this schematic that, it all starts with diabetes, and unfortunately uncontrolled diabetes. Some patients may not even know that they have diabetes, and so it goes undiagnosed and therefore uncontrolled for a long period of time. Some people, are, again, non-adherent with treatment, and again, that could develop into uncontrolled diabetes. And some patients are really good and they try to control their diabetes, and they're really, good about glucose management and checking their A1C and their daily glucose levels. But sometimes, unfortunately, they can still develop consequences of long-standing diabetes. So what are those consequences? Let's look at, first off, the somatic sensory neuropathy. I think this is what most people relate to diabetes, is when patients have lack of sensation. So they don't feel pain, they don't feel temperature, and they also have lack of proprioception. So what's proprioception? That means like where the body part is in the space. So a lot of our patients will have some gait abnormalities and possibly have some issues with tripping or instability because of that neuropathy. And again, we see this sensory neuropathy, so lack of sensation and sometimes painful sensations. A lot of patients will say, have a lot of burning and tingling in my feet, particularly at night. That's one of the most common types of neuropathy, and the most common things that we'll see as symptoms that patients will relate to us. And what can happen is repetitive trauma, ill-fitting shoes. I've seen patients walk down blacktop driveways in the middle of summertime and get third-degree burns on their feet and not feel a thing. I've had patients, step into boiling hot bath water and get burns. And they didn't notice until it was too late. Patients have stepped on just about everything, thumbtacks, nails, toothpicks, pieces of glass. They don't even know that they've had an injury until, they see bleeding on the sock or some purulent discharge, or have, see an odor. So, we know a lot about that sensory neuropathy, but we don't really pay as much attention, I guess, to somatic motor neuropathy. So the small little nerves in the feet that innervate the muscles also can waste and be dysfunctional with long-standing or non-controlled diabetes. And what will occur then is those small muscles will waste. So those interdigital and interossei muscles won't get the nerve function. And so what patients will end up developing is foot deformity, so structural abnormalities. So they can develop hammer toes or bunions, and these are increased pressure points. So combined with that sensory neuropathy, they have a bunion or a hammer toe, they have a poor fitting shoe, and that's an area that'll rub and break down. We also have to discuss an autonomic neuropathy. So patients with diabetes can develop neuropathy. This can lead to decreased swelling or sweating rather, and dry skin and callus formation. You remember that patient I showed you at the start of the talk with all that dry skin? That's because she had also developed autonomic neuropathy, and what will happen is the skin will be more friable, more sensitive, and then more fraught for breakdown and ulcer development as well. Peripheral arterial disease is something we commonly see in our patients with diabetes. So patients with diabetes and coronary artery disease, I can bet the farm they also have peripheral arterial disease. So our patients should be monitored. We should at least get non-invasive vascular studies annually. Any patient with a diabetic foot ulcer definitely needs non-invasive vascular studies, ABIs, TBIs. We'll talk about that in a bit as a baseline, and then to track the patient throughout their course of care as well. So the at-risk foot screening is very important for our patients with diabetes. And again, preventative measures and preventative medicine should really be in the forefront. Foot screenings are important. It'll help clinicians and help patients assess their ulceration risk, that loss of protective sensation we talked about, that sensory neuropathy caused by that diabetes and the neuropathy that develops through the myelin sheath is really a key component of the diabetic foot exam, tracking that, getting a baseline on a new patient, and then tracking it every visit. It's been well documented that the simple Sims-Weinstein monofilament wire is a great way to do this with your patients, and it helps us to assess their risk of ulcer development. So remember, loss of sensation and the PAD, those are highly predictive that a patient will develop an ulceration at some point in their life. We also have to manage these patients by protecting their feet. Protecting the at-risk foot is really key, and patients shouldn't be encouraged not to walk barefoot, really not to even walk in socks or thin-soled slippers, because if they were to step on something and they have neuropathy, it would go through a thin-soled slipper or a sock without any problem. And they really should wear something with a substantial sole, something rubberized in the house as well as outside the house. Elevated plantar pressures are also a significant independent risk factor for a diabetic foot ulcer too. So even if they say, oh, my house is very clean, I don't need to wear, any kind of protective shoe gear in the house, it actually also indicated to decrease those plantar pressures to hopefully prevent skin breakdown. So getting a nice thick-soled moccasin type house shoe, or wearing a pair of tennis shoes in the house, and they can just keep it, just for housewear only, so they're not tracking debris in from outside, is what I recommend to my patients. Here's a case, 82-year-old male, insulin-dependent diabetic. He had had a fifth toe amputation at another hospital center. He had initially had a trauma to the fifth toe while walking barefoot. He actually stubbed it on a piece of furniture at his home. Who hasn't done that, right? Unfortunately, because of his diabetes, he had had a cut in the skin that became infected. He had some poor blood flow to the area. The fifth toe became gangrenous and then ended up having an amputation. Well, you can see, unfortunately, prior to the amputation, the treating clinician did not assess the blood flow or optimize blood flow. So the area continued to deteriorate. You see some gangrene present, some necrosis. We see that fourth toe is real dusky, doesn't look good. We have a non-healing ulcer where the amputation plate was placed. So he came into our clinic because at that neighboring facility, he was only given the opportunity for a below knee amputation. Now, he was 82, but he was a fry 82. He has grandkids and he's a golfer. So he was not happy with the only option being a below knee amputation. So we did some non-invasive vascular studies. We did an ABI, an ankle brachial index, and we found that it was 0.6. So he was on the edge of critical limb ischemia. And we decided to go ahead and send him to our vascular surgeon for a workup to see if we can salvage his foot. Let's talk about what an ABI is and the importance of an ABI, excuse me, when we're assessing the diabetic at-risk foot. So just palpating pulses isn't good enough. I see that a lot in our charting, palpable pulses. And, don't be fooled by palpable pulses alone. In fact, a study showed that 52% of patients with palpable pulses, we were actually palpating our own pulse. And then another study showed that even with an ABI, the ankle brachial index, patients that had palpable pulses had a low ABI. So don't be fooled by palpable pulses. Get some screening studies, ABI, and then I also would advocate for a TBI as well. So again, the ABI is ankle brachial index. You take the blood pressure of the arm and then around the ankle, and you make the calculation. And you can see that between 1 and 1.4 is normal. Sometimes patients with diabetes will have hardening of the arteries, and therefore their ABI will be falsely elevated. So when you get an ABI in a diabetic patient that's 1.4 or higher, don't be fooled by that. It doesn't mean they have really good blood flow. It actually means that their vessels are calcified. So we're getting an abnormal elevated ABI. Acceptable range 0.9 to 1, mild peripheral arterial disease 0.8 to 0.9, moderate 0.5 to 0.8. And this is where I start to get vascular involved, at least for a second opinion, to see if there's any way we can optimize or increase blood flow. And then anything below 0.5 is severe, that's critical limb ischemia. So toe brachial indices I find a bit more helpful in our diabetic patients. Again, we talked about that there's calcification of the vessels, the large vessels in the leg, and it could show us a falsely elevated ABI. Not only could it be falsely elevated to the point of 1.4 greater, it could actually be falsely elevated in when there is peripheral arterial disease. So it can make us think we have a good ABI or good blood flow. And then in some rare cases, I shouldn't say rare, in some cases, we can get back a report that says the vessels are non-compressible. I'm sure you guys have always had all experienced that. And so when you send a patient for an ABI and it comes back non-compressible, that means that their calcified vessels couldn't be compressed, so they couldn't calculate an ABI. So that's why I advocate for not only an ABI, but also a TBI, so a toe brachial index. You'll see that although the patients do have microvascular disease and some calcifications in the small vessels of the foot, the toe brachial index is probably a better test, a better screener for what blood flow is distal to the ankle. And obviously with diabetic foot ulcers, that's where the problem is. So a TBI of 0.5 to 0.75 or greater is good. That means they have that distal blood flow, and they should have a decreased propensity of skin breakdown. And then also, if they should develop a diabetic foot ulcer, they have a good chance of healing that ulcer because they have adequate blood flow. So talked about, the ABI versus TBI, and there's a lot of evidence out there to support it. There was a study that was done from July of 2011 to February 2013, and there were 89 patients that had a CLI, critical limb ischemia, and then had non-invasive testing done, that ABI, for complaints like rest pain, for minor and major ischemic tissue loss. So we know that those are the symptoms we see for critical limb ischemia. And even among those patients that had minor and major ischemic tissue loss, 29% still had a decent or normal ABI of 0.7 to 0.4. So in conclusion, the authors felt that in CLI, nearly 1/3 of the patients with ischemia, severe symptoms of critical limb ischemia, had a normal or only slightly reduced ABI. So that TBI is a better assessment for our patients even in light of critical limb ischemia. So keep that in mind. So remember that patient that had that fifth toe amputation and the gangrenous changes and a lot of devitalized tissue with that 0.6 ABI. So we sent him to vascular. He was revascularized to optimize the blood flow. And then I went ahead and took him to surgery. I did a transmetatarsal amputation, and he went on to healing incident. He was transitioned to diabetic foot or diabetic shoes with a toe filler. And I think it's really important, once you get a patient to heal, a patient that has diabetes that's uncontrolled, has neuropathy, has previous, gangrene or infection or ulceration, and you finally get him healed, now you have to ask yourself, now what? Because these wounds tend to be highly they come back. The recidivism rate for patients is really great. So you have to work with your podorthist or your prosthetic specialist in your area or your hospital to get these patients into a well-fitted shoe with a toe filler if needed to prevent any kind of tissue breakdown or further tissue breakdown from developing. And again, education with these patients is really important. So don't transition a patient like this after surgery and after healing an ulcer just back into regular shoes, because I'll guarantee you they'll continue to break down. They'll be in your office in the next couple months. And, everybody's so excited when we heal an ulcer, but when the patient was come back, we kind of become deflated. So remember, patients with a loss of protective sensation and peripheral arterial disease are at greater risk. But even patients with diabetes without loss of protective sensation or peripheral arterial disease should still have screenings. We want to, again, prevent any problems from happening. We want to check that loss of protective sensation. We want to screen their ABIs and TBIs to see, where they're going through time. So an annual foot exam would be indicated for those patients. Now, when loss of protective sensation and or peripheral arterial disease is identified in patients, that's when we see our patients a little bit more often, and we do more extensive foot screenings because those patients have a higher risk. And typically what we're looking for in those physical exams is fat pad atrophy. We're looking for a lot of callus or skin fissures, hammer toes, bunions, again, those structural abnormalities, limited joint mobility, which will throw off ambulation and also increase pressure points, and then any kind of skin and nail disorders. You can see on this patient, this is a diabetic patient, has this terrible callus formation on the plantar surface. And, I want everyone to relate finding a callus on a diabetic foot equal to finding a lump on a breast. I mean, it really needs evaluated. You need to take off that callus, debride that callus. You need to offload that area. You need to have proper shoe gear. Again, patient education is important, diabetic management, and possibly even having the patient see a dietitian is important, making sure they're taking their medications and checking their glucose because you don't want this to break down to an ulcer. Just finding a callus, oftentimes it's just not a callus. You can see in this patient, he had been seen by his primary care doctor, complained of a callus. The primary care doctor, didn't have much to say about it, really. Patient continued to walk on it. Then all of a sudden, it became red hot painful. There was a little bit of fluid underneath it. Came to me, deroofed that callus, did a good thorough debridement, and sure enough, patient had developed a diabetic foot ulcer. So we want to prevent it when it's just a callus. We want to stop it from forming. We don't want an ulcer to develop. And this is why, if you look at patients' 5-year mortality rates, they skyrocket once a patient develops a diabetic foot ulcer or has to undergo a lower extremity amputation. In fact, the 5-year mortality rate in these patients is greater than those patients with prostate cancer or breast cancer or Hodgkin's disease. So it's a huge deal. And I don't think it gets as much attention as it probably should. You don't see professional athletes wearing a certain color for diabetic foot ulcer prevention like they do with breast cancer. And but maybe they probably should. So we talked about the importance of, not only that sensory neuropathy, but also the motor neuropathy and really the bad outcomes that can develop when those motor nerves become demyelinated. And we'll see a significant plantar muscle volume loss, and those hammer toes develop, bunions develop. Additionally, patients will have slower walking speeds. So the plantar pressure increases because their ground reactive forces increase. That loss of proprioception will lead to increased falls and increased trauma. We know that this occurs with our older population. They're more fraught for risk of developing traumatic injuries because of instability of gait. When we talked about the autonomic neuropathy, that friability of skin, and really it's the perfect storm for patients with longstanding diabetes, uncontrolled diabetes, older age, for being at risk for severe problems to develop. So let's talk about the frequency of at-risk foot screenings. And it's really based on the findings of the patient. We could stratify how often they should be seen. In these guidelines are the International Working Group of the Diabetic Foot. And this is, again, international consortium. They are a really great resource for any kind of information or treatment algorithms for the diabetic foot. And their recommendation is, patients that fall into category 0, they don't have any loss of protective sensation or peripheral arterial disease. Their risk of ulceration is low. Those are the folks we can see annually. If a patient is in category 1, they have low risk. They either have loss of protective sensation or peripheral arterial disease. We should see those patients at least twice a year. Now, when they get into that moderate phase, that category 2, they have loss of protective sensation and PAD, or they have loss of protective sensation and foot deformity, or PAD and a foot deformity, then we should see them fairly regularly. Every 3 to 6 months would be indicated. Now, for our folks that are in our high risk category, in category 3, they have loss of protective sensation and or PAD, and a history of foot ulcer, or a history of lower extremity ulcer, or even at risk because they have end-stage renal disease. We see them very frequently, every 1 to 3 months, to do an at-risk foot exam. So we talked about, some of these trophic changes that can occur in patients with diabetes, and one of it was one of the things I mentioned was adipose tissue wasting or loss of that fat pad. Diabetes will compromise a fat pad underneath the heel and the metatarsal. That's our natural cushion for when we walk, again, against those ground reactive forces. The fat pad is made of these collagen fibers, and poorly controlled diabetes will lead to glycosylation of the collagen fibers, and that will lead to the collagen thickness in the fat pad to decrease until we lose that natural cushion, and the patients will be walking, almost on the bone, especially underneath the metatarsal heads, and that's an area that we see a lot of callus formation, skin breakdown, and then ultimately ulcer development to occur. These are the toe deformities we spoke about. Because of that motor neuropathy, hammer toes are actually reported in a great number of our diabetic patients. It's been estimated 32 to 46% of patients with diabetes have hammer toes because of that muscle wasting. It's a common cause of ulcers on the forefoot, and the presence of a hammer toe in one particular study was noted to be the most important predictor of plantar pressures. So not only having a toe ulcer or hammer toe rather, you can get bottom of the foot problems as well. So we get that retrograde pressure of the toe sitting on the metatarsal head. It sits down more plantarly. You have that plantar fat pad atrophy, so you don't have that cushion. So you're kind of like walking on a marble. Patient develops callus, skin breakdown, ulcer development. So the toe deformities in diabetics can be a problem. So that's something definitely to assess and address when you're looking at your patients with diabetes. Here's a case of a patient that had a toe deformity. He had a hammer toe, and you can see his second toe is a lot longer, so obviously has some some nail dystrophy as well. This 57-year-old non-insulin dependent diabetic, he was admitted to the hospital with a red hot swollen foot after wearing a new pair of shoes. Obviously, the shoes probably didn't fit him well, and so he developed an area of rubbing that became infected. A full workup showed that he had gas in his tissues, abscess, and then unfortunately osteomyelitis of the second metatarsal. So patient had to be taken to surgery, and we did a partial first ray amputation, partial second ray amputation. He took part of the metatarsal, took all the toe, part of the metatarsal down to the shaft. Patient was placed on 8 weeks of IV antibiotic therapy, negative pressure wound therapy was utilized to help to granulate the area in. And you can see long term, this is what the patient looked like. So to him, he didn't want to have anything too aggressive done. He just wanted the toe taken care of. And we were able to get that healed. It was a long road for him. And I suspect he probably ended up having problems down the road. I didn't care for him long term, but at least we were able to salvage the majority of his foot and get that initial injury to heal. Now, this patient needs good shoe gear, good medical support, and proper education to keep him out of harm's way. So I'm going to talk to you about a project that we developed with the engineering students and then also the podiatry students at the university. And I think this is a great way that different disciplines can collaborate to help to support these patients and really, again, note if there's a problem or stratify the risk so we could better equip the patient to prevent problems down the road. So this is a study that we talked about, the early detection of diabetic foot disease. And what was developed is by the biomechanical engineering students was this shear and pressure evaluating camera system, and they called it SPECS. And they were curious to see if they could pick up early Charcot changes. And again, this is what long-term or late-stage Charcot looks like. Patients have severe structural abnormalities. You can see that rocker bottom foot type. Toe deformities you can see are present in this patient. These patients have a really high tendency to ulcerate because those midfoot bones are now very prominent plantarly. They've had fat pad atrophy or decrease of that natural cushion. So those areas that they're walking on will break down and ulcers will develop. And a lot of these patients will end up with an amputation long term. Let's talk about Charcot for a minute. So Charcot syndrome is a serious and life-threatening condition that develops in the lower extremity. We see it a lot in patients with diabetes, but patients with other neuropathy, either alcoholic neuropathy or other toxicities, or even neuropathy because of, the surgery or impingement in the back. But most commonly, we see Charcot in patients with diabetes. Patients with a history of diabetes and that peripheral neuropathy are at a higher risk for what is called a neuroarthropathy. That's what Charcot is considered. It's also considered an inflammatory condition. And what develops is varying degrees of bony destruction, disorganization, and that leads to that rocker bottom foot appearance. It's usually caused by minor trauma, sometimes a major trauma, but it can be as simple as a screen door shutting on a foot. I've seen that happen before, or a patient kind of stepping off a step in a weird manner, and then it kind of just causes this cascade of abnormality of bone metabolism. And what patients will develop is this dysfunctional foot. Will have this midfoot soft tissue ulceration that could develop infection. And like I said, long-term amputation occurs in most of these patients. So unfortunately, Charcot is still a challenge today. There is little solid evidence on, like a gold standard treatment. Interaction of diabetes at sensory neuropathy, autonomic neuropathy, trauma, metabolic abnormalities, kind of like this perfect storm that leads to bone abnormalities. And the hallmark is that rocker bottom foot. There's no singular cause, as you can see, but once triggered, it's really a process of uncontrolled inflammation. The bone is fractured. There's release of these pro-inflammatory cytokines. With the patient's loss of sensation, patients kind of walk through it. They continue to ambulate and have these repetitive stresses, so the bones continue to break down, and we see this cycle of osteolysis or osteoclastic activity. Now, what we like to do when we catch this early enough, we want to immobilize the patient. We want to stop that walking and ambulation. Usually we do it by casting the patient and trying to get them to be non-ambulatory. There are some other medications or some IV medications that are showing some promise. But again, there's really no gold standard. And unfortunately, we tend to see these patients when it's kind of too late, when some of this bony abnormality and these poor processes have occurred already. So initially we see the Charcot manifestations as mild, but increase with repetitive trauma. There's been no reported cases of Charcot without neuropathy. And again, it doesn't have to be diabetic neuropathy, although that's the majority of causes. Sometimes it can be alcoholic neuropathy or neuropathy for other reasons. Early sign is usually local inflammation. And, it looks like cellulitis or DVT or even gout. So you have to have a high incidence of suspicion with patients with diabetes, especially those with uncontrolled diabetes and maybe a remote history of trauma or minimal history of trauma. And we can detect that there's a degree of difference in the temperature between two limbs. But really the dead giveaway is when pedal pulses of the affected limb are bounding. So that should be an indication that, maybe there's a Charcot process. So there's 3 stages of Charcot that are recognized. We have the acute, which is the destructive phase, the subacute, which is the reparative phase. The body is trying to repair all the damage, kind of put Humpty Dumpty back together again, if you will. And then our patients that have the chronic or stabilized with that rocker bottom foot. Unfortunately, we mostly see patients in that subacute or late acute or subacute stage, or even that chronic phase, because of that lack of sensation. They just don't get to us early enough. So again, we don't see the structural changes in the acute phase. We might not make the proper diagnosis. We might think it's cellulitis. Patients might be put on several rounds of antibiotics. They continue walking on it, and then the destruction occurs. The best way to really make that diagnosis is by imaging the foot. X-rays have some utility, but really MRI would be the preferred method for early diagnosis. It can help us to reveal ligamentous disruption, subchondral bone changes. We could see soft tissue edema. We could see bony edema and bone marrow edema. And then we could see some malalignment of the foot as well. So that tends to be the better choice for radiographic analysis is an MRI. So can we predict which patients might develop Charcot over time? And then you could see there could be utility there, right? If we could check these patients, we know they have an increased risk and they could take measures to prevent it from occurring. We could really help these patients long term. So this study examined patients with diabetes, but no other risk factors or no other signs and symptoms from a biomechanical aspect. So their foot looked normal. They had diabetes, but the foot structure was good. Again, rationale, if we could, detect these early changes. Sorry, my overhead light went off. And we could, provide more stability, be it bracing or shoe gear. Again, patients long-term could really have better outcomes. So this was a custom-built shear and pressure evaluation camera system, otherwise known as SPECS, and it is able to measure simultaneous vertical and horizontal contact forces that interact between the foot and the ground during gait with a good resolution of 1.6 millimeters by 1.6 millimeter. And this is what the device looked like. So it was a box with cameras. There was an LED light bar and mirrors that were mounted, and then a base plate, which had a force sensing plate at each corner. And the patient simply walked over the camera device, and various photos were taken during that gait, and different assessments were obtained. So we use this camera device to evaluate a group of patients with diabetes and peripheral arthropathy or neuropathy without any signs of Charcot. And then we also had our control cohort. These were non-diabetic patients. So both groups were evaluated and we compared the data. Initially, the subject group had no difference in the longitudinal arch. So patients with diabetes and those without diabetes, our control group, their longitudinal arch was the same. Again, no structural abnormalities. The only difference was one group had diabetes and peripheral neuropathy the other day. So this is what the photos look like as the patients walked over the camera system. You can see it detects various degrees of pressure as the patients ambulated. So this is what information we obtained and some of the conclusions that were drawn. What we saw in the patients with potential for collapse is there was a ratio of shear forces under the hallux and the first metatarsal. There was a difference in the anterior posterior shear forces at the ground foot interface between the calcaneus and the first or the fifth metatarsal heads. And there's a difference in the medial lateral shear forces under the first and fifth metatarsal heads. And overall, there was significantly higher outward shear forces along the medial arch and the longitudinal arch or lateral arch. Transverse arches were found in the neuropathic diabetic patients also. And this was statistically significant. So the patients with potential for developing Charcot had greater shear forces along the medial, lateral, and transverse arches of foot. So we can detect this by the camera. We couldn't detect it by the naked eye or our regular foot assessments, but the camera could detect that. And again, it was statistically significant among the different groups. So this is what we found, those anterior posterior shear forces. You can see in our diabetic populations, they were a lot greater than the patients that were in our control group, those non-diabetic patients. So the conclusion was that this data supported the idea that the neuropathic diabetic patients are less capable of really opposing those outward shear forces. So they just didn't have the ability, probably because of the motor, sensory, and autonomic neuropathy that we talked about, and therefore the collapsing of the arch was greater propensity in these patients. So we thought, because of this camera and using a camera or something like this, it could be a new tool for clinicians to identify these early changes in patients that are at risk of developing Charcot deformity. So thank you for your time. A couple of the points that I want you to kind of leave this discussion with is diabetes obviously is a very complex disease. There are many serious sequelae, a lot in the lower extremity. And it's all too common that patients with diabetes will develop problems in the lower extremity, in the feet, ulcerations, again, Charcot, infections, amputation, and it's often too late. Patients don't take the time to do foot exams. They wear inappropriate shoes. They could have injury. They don't detect ulcerations until either they become very large or infected. And we know that in these patients, these ulcers can deteriorate quite quickly. and frequent screenings is really important. So clinicians need to have, a really good incidence of suspicion for these patients, see our patients more quickly. An ounce of prevention is worth a pound of cure, as they say. We need to assess them for perfusion, make sure we maximize their perfusion. We need to encourage regulation of their diabetes and control of their glucose, proper offloading, proper shoe gear, proper foot checks, and all the preventative measures, education included, can really help us to give our patients better outcomes. So the focus should be there. And an informed patient is, I think, a more compliant patient. Getting the patient on board, having them be an active participant in their care, and really part of the team is super important. And I think that education is part of it. And studies have even shown that diabetic patients that are educated can help to decrease amputation rates by 50% or more. So here's my contact information. If you want to reach out to me with any additional questions or ask about a case or more about the SPECS camera, whatever the case may be, this is how to contact me. And again, I appreciate your time and attention, and it's been a pleasure to give this presentation. Thanks so much.
Thank you so much.
You're welcome.
Always appreciate your knowledge, your expertise, and always great to see you. And I will see you soon.
Okay, sounds good. Thanks so much, Rich.
Bye-bye.